Thank you, Mr. President, for the kind invitation, and thank you, Mr. Chairman, for the generous introduction. It's always a great pleasure and honor to be part of such an esteemed scientific meeting and to have the opportunity to share and exchange knowledge with distinguished colleagues and experts in that field. Today, I'll be discussing the treatment of secondary hyperparathyroidism in non-dialysis chronic kidney disease patients, a topic that has generated considerable interest and ongoing debate in the recent years, particularly following the KDIGO guidelines updates. First of all, my disclosure of interest, I'll let you take a brief look at this. And now I'd like to go ahead with my content of my presentation. Just as an introductory slide, what are we dealing with? This is a syndrome of chronic kidney disease, mineral and bone disorder, because the previous term, who were renal osteodystrophy, covered the bone complication of chronic kidney disease, but it did not tackle or cover so much about cardiovascular part, especially vascular calcification and its relationship to mortality. طبعا, it is also related to the mineral balance or hemostasis. Now, the pathophysiology basis, as you can see on the slide on the left side, you can see more the traditional view of how secondary hyperparathyroidism occurs in the context of CKD and MBD functions, because in kidney disease, in a way, it leads to disturbance in terms of less activation of vitamin D, which directly kind of disinhibit PTH release from the parathyroid gland, but also leads to transient or even continuous presence of hypocalcemia, which centrally can stimulate PTH release. Now, we know from studies that also hyperphosphatemia triggers the parathyroid gland to release PTH. But we thought that in the past that this was a relatively late event in the course. Now, if you look at on the right side, you can see another hormone is present, which is the FGF23. And this is probably the first hormone to get dysregulated during the course of chronic kidney disease. And this has obviously the task with PTH to keep the hyperphosphatemia or to prevent hyperphosphatemia, especially at the late stages of chronic kidney disease. As a second action of FGF23 directly stops or inhibits hydroxylation and activation of calcium. Now, if you look at the gland level, what occurs first is that there is a kind of polyclonal hyperplasia of the gland, which still is relatively perceptive to treatment because the calcium sensing receptors and the vitamin D receptors are only modestly downregulated. When it comes to in the course of hyperphosphatemia, especially with regards to progression of the disease, you will get nodularity and adenoma-like structures that occurs. And these get less and less susceptible to treatment that we apply or we tend to stop its progression. So this is the goal of what we are trying to achieve to prevent the progression from a diffuse hyperplasia to a specific monoclonal hyperplasia in order to prevent therapeutic resistance and not reaching the parathyroidectomy. And this is, of course, a related topic that we're going to be talking about. Maybe we can leave it for discussion at later in the presentation. Now, with regard to the present guidelines in covering the situation in non-dialysis patient, well, I'm sorry that the first statement is funny somehow. It says that in patient with chronic kidney disease 3A25 not on dialysis, the optimal PTH level is not known. And this is, to a certain degree, is true. But of course, this is not very helpful because we don't have a good clue when to initiate or when even to stop treatment and when not to overtreat the patient with hyperparathyroidism, because some elevation in PTH is probably something good for coping with the changes that occurs during the progression of kidney disease. Now, the guidelines are clear in one thing, that you need to individualize your patient and treat مثلا hyperphosphatemia, hypocalcemia, high PTH accordingly. So individualize your treatment, and something Kamal will talk it during the progress of our talk. So what are the renal effects of PTH? So PTH increase reabsorption of calcium and thus recovering, for example, hypocalcemia. It also induces reabsorption of magnesium, and it inhibits reabsorption of phosphate. So PTH together with FGF23 is a strong contributor to diminish or inhibit and to protect the patient from hyperphosphatemia. And then it stimulates the enzymatic conversion of vitamin D25 OHD into active calcitriol. So the calcitriol deficiency in a way would be counteracted by PTH. And in addition to this renal effect, PTH also affects the bone. And with patient getting more uremic, and in uremic patient, in the course of their chronic kidney disease, the bone gets unresponsive or less responsive to PTH action on turnover. And so the bone for normal turnover probably will need a little bit higher PTH. Now, if you look at the analysis of time course, or perhaps the three most important scenarios of chronic kidney disease MBD, it shows that indeed already in CKD stage 2, about 30% of the patient may have elevated FGF23, and we said it's the first to be dysregulating chronic kidney disease, as you can see, 30% at start, and that and here is only 10% of PTH is elevated. But the PTH, you can see here, the PTH stimulation above the normal occurs in CKD stage 3A to B in about 1/3 of the patient, in half of the patient in 3B, and in 70 to 80% of the patient in stage 4 and 5. So this is something that is of importance. However, this means that PTH rises above the normal range is important somehow to keep the balance and the turnover in bone. يعني it's important to keep it around 2 to 3 times the normal. طبعا we'll talk about it later on in the presentation. Now, just one look at the tubular side with regards to hyperphosphatemia and phosphatidyuria. It's now became very clear in the last 10 to 15 years that both PTH and FGF23 inhibits the two key sodium phosphate co-transported at the kidney level, اللي هما NAP2A and NAP2C, by distinct intracellular mechanisms. So the body indeed employs two hormonal systems in order to protect us from hyperphosphatemia, which at least some may indicate the importance to help and save the body from damage. Yani hyperphosphatemia by itself has its own comorbidity and mortality. And looking again the sequence and in the time course of events, in a way, PTH elevation is the third step in the development of chronic kidney disease MBD. So the first one, as we said before, it is the FGF23, the FGF23. Okay, this directly followed by the inhibition of calcitriol hydroxylation, and when this occurs, PTH levels go up and phosphate or hyperphosphatemia occurs late. So the question is when to tackle the elevation of PTH, and at what level or under which circumstances, and this is probably not an easy decision or a question to answer. And in this regard, the new guidelines update, which is 2017, the last update, but up to now, 2016, there wasn't much of a change. But the difference between 2017 and 2009 regards to vitamin D, the guidelines suggest treatment with calcitriol and vitamin D analogs, when PTH start to rise and remains elevated, that's in 2009, to start using vitamin E. Now it's said that these calcitriol and the active analog should not be routinely used. It should only be used in later stage of chronic kidney disease, which is below مثلا 30 GFR of 30, and in patients with severe progressive hyperparathyroidism. But the question again, how to define severe and progressive hyperparathyroidism? And we may probably again come to this and later on the discussion because again this is not an easy question to answer. Now, in that regard, why we're not using vitamin D except in late stages, it's because of two studies. This is based on two studies. One of those studies is the PRIMO study, published in 2012, where around 230 chronic kidney disease patients were enrolled in order to look whether paracalcitriol had a beneficial effect on the progression or regression of left ventricular hypertrophy. طبعا it was the comparison to placebo, and the LVMI was measured by echocardiography and also supported by MRT scans and followed for 1 year. Now, the basis of the study was that in animal models and in small pilot trials in dialysis patients, vitamin D showed some biological beneficiary effect on cardiac remodeling. Now, this is the key result for this study. There was no difference in the LMVI between patients with placebo and the paracalcitriol. Actually, after 6 months, there was a significant advantage in the placebo group, and patient was not taking the one who was not taking the vitamin D analog. And because of the hypercalcemia episodes were more frequent in the placebo group compared with the placebo compared to the placebo group, and the difference was almost 23 to almost 0 patient in the placebo group. And here is the graph to show that if you this is the one when you use paracalcitriol, of course the PTH is lower, and those risk of hypercalcemia was almost 23%, and that's why the cardiovascular disease possibly was related to the use of vitamin D. But again, you really have to individualize your patients, and again you have to be careful, but you don't want hypercalcemia, and at the same time you don't want hyperphosphatemia. Now, this is only also the OPERA study from Hong Kong showed a similar picture, even with the lower paracalcitriol doses of 1 microgram per day. There was no difference in the left ventricular mass index endpoint even after 1 year, and there were also much higher serum hypercalcemia occurrence in the paracalcitriol, actually more than 40%. Now, nevertheless, it looks as if early or as secondary hyperparathyroidism control prior to entering dialysis may be of some significance. The importance here إنه before entering dialysis, your PTH need to be controlled. Sometimes you may need to use vitamin D. And this recent paper is a DOPS analysis that looked at a total of 2,800 patients for PTH outcome analysis before and during entering the dialysis stages and watching them for almost 1 year. Here you can see the distribution of different PTH level in those patients when they become incident dialysis patient, and fortunately the largest group was in the range of 100 to 300, mostly around 150 to 300 picograms per ml. But you can see here also that there is elevation of above 450, where sometimes present in more than 30% of the patient, or even في بعض المناطق بتلاقي of more than 40% of the patient. So this indicates some kind of potential therapeutic resistance, no higher PTH. And here is what happens with the treatment. Once those patients start dialysis, depending on their previous PTH counts, you can see that, for example, those patients with the highest incidence and the highest level of PTH, about 70 to 80%, had received active vitamin D compound at 1 year, and about 20% of them, this is very important, 20% of them had to receive calcimimetic agent. يعني if you enter with a higher PTH, more than 450, you're more likely to use calcimimetic agent by more than 20%, and that can be said it is the resistant. So if you enter with a lower PTH, it may you probably will be able to control it better. And if you have it more than 450, you need to use calcimimetic agents more, and that's economically can be affected. So if you have it lower than 300, you're probably less than 5%, you will need to use calcimimetic agents. So nevertheless, looking at the last part here, for example, in those patients who started with level above 600, about 2/3 were able to be lowered to, or 60 were able to lower into the range of below 450, and 70 below the level of 600. So treatment efficacy is still pretty good, and even when you start in a good circumstances or conditions, you're still able to treat those patients. Now, what about vitamin D? Now, the KDIGO guidelines were just continuing about the same in 2009 guidelines, where what they were saying that the general recommendation was that the vitamin D deficiency and insufficiency be corrected using treatment strategy recommended for the general population. Okay, so what is recommended for general population? This is still a very way to go back to the same thing. Will Institute Medical or Medicine recommendation from 2010 to 2011 and did not change. And based on a large systemic review, this is طبعا a PDF for around 80 pages. The recommendation was serum level of for 25 OHD of 20 to 60 nanogram per ml, and they also said that 600 to 4,000 units per day of vitamin D3 are safe and do not lead to overkill or adverse effect. طبعا some of those based on the given result of vital and do health studies or analysis. Now, in addition to the IOM, especially the Endocrine Society guidelines and the early NFK-DOKI guidelines recommended a higher range of 30 or above 30 nanogram per ml for 25 OHD. And this is more addressing the situation for risk prevention of osteoporosis, because it occurs in patients with chronic kidney disease. And nevertheless, the KDIGO recommendation now, in a way, suggests at least above 20, and I prefer more than 30 because more studies have shown it does is more helpful, but more than 20 is okay. And whether this is the right recommendation, we can come to it in our discussion. Now, what do we know about the relationship, for example, of 25 OHD levels and the active vitamin D? Now, this is just an observational and not an interventional trial, but in these patients with non-dialysis chronic kidney disease, the vitamin D of the 25 OHD levels correspond relatively well with the calcitriol levels. So the less vitamin D deficiency, the higher the calcitriol availability, and vice versa. The less deficiency, the lower the PTH level, and the more vitamin D3 deficiency, the higher the PTH level in these observational studies. And from the same study, a distinction about the count of severely deficit patient versus the less deficient patient. So 25 OHD of here, مثلا, less than 50 nanogram per ml were associated with faster progression towards dialysis and with a higher mortality rate. يعني if you have a vitamin اللي هو 25 OHD levels less than 50, you are more likely to end up with end-stage renal disease and on dialysis, and your mortality rate is higher. طبعا we'll talk about it because it has again some relation to PTH, as we said in the previous slide, and we'll talk about it at further slides later on. Now, what we know here about the relationship of vitamin D status and PTH level. Again, this was published probably more than 10 years ago. For example, in this meta-analysis, studies were cited, where the impact of vitamin D supplements on PTH were studied. And you can see here in the above panel that all of these four studies led to more or less significant increase in 25 OHD levels. And that was significant and measurable, as you can see here. But, however, in none of these studies, the PTH was affected, although one can say that the prevention of a rise in PTH or freezing it at that level or at the baseline may already been a therapeutic effect, but this is hard to prove, and I just wanted to mention this. Possibly we can talk about it again in a potential for discussion. Now, this is an important point, though is probably interdependence of bone biomarkers and the control of the biomarkers. I already mentioned that PTH, calcium, phosphate are interrelated. FGF23 is an important player in vitamin D, and they relate to surrogate parameters like vascular calcification, bone abnormalities, and PTH. And this would relate to direct and meaningful outcomes for patients. طبعا including the cardiovascular disease, fracture risk, and even the need for parathyroidectomy. And if you look at the KDOQI guidelines update, which is 2017, which we're still using it up till now, they point out the fact that we should all consider values اللي هو phosphate, calcium, PTH under one unit together before we just try to turn the screw on by adjusting one parameter, because you may actually affect the whole parameter. So you really have to be extremely careful and individualize your treatment for your patients. Now, what do we know about PTH and mortality in non-dialytic chronic kidney disease patient? And here is indeed, for example, in this trial from the US, suggesting that an increase is reflecting a bit of a higher risk in mortality rate. Here you can see the hazard ratio. So if you have it within normal range, but if you increase it to 2 times, but if you go above 3 times the normal, you can see that if you go more than 3 times the normal range, it tends to be, it affects the mortality. So when levels are above 3 of the normal range, there is a relationship of which is statistically significant. So PTH that is higher than 3 times or 4 times normal, it has significant effect on mortality and morbidity. Now, for PTH and fracture, it has been shown that fracture rate is, first of all, gender dependent. We know that. So women, and this is similar to a normal population, break their bones independent of chronic kidney disease stages more frequently than men. Now we're looking at the stages. With any stage, there is some degree of an increase in fracture risk. This is a 3-year cumulative incidence, and when the PTH at this time is already very high, above تقريبا 900, versus if it's less than 300 or 150, 300, this is frequently increasing, and fracture increase. And patient with fracture, when compared to the group of patients without fracture, on average, the higher PTH, they have a higher PTH level. So this is another indicator that higher turnover bone disease may contribute to further to be pre-existing osteoporosis. And when we look at the different vitamin D associated treatment effects, we have few choices. We can try like the recommendation for osteoporosis protection prevention, use D3 cholecalciferol, where we get the 25 OHD levels up with, as you can see here. So if you use it, you can go up, but it has limited effect on calcium, has a probably كمان limited effect on PTH and limited effect on FGF23. But if you use the طبعا in some European countries, an immediate release 25 OHD calciferol is available, which has at least from the study that we have published have a relatively similar effect like the native D3. Now all active analogs, including calcitriol, paracalcitriol, or 1-alpha, and so on, they, by feedback mechanism, lead to some increase in 25 OHD levels, but they tend to increase the calcium and phosphate, okay? But they all have a very potent in order to decrease the PTH level. So they do decrease the PTH level, but the problem is they increase the calcium and phosphorus. And I think most of us would agree that the beneficial consideration could be to get further increase in 25 OHD levels that may have an impact on PTH. And this is probably the best combination. So you want to increase the 25 OHD and at the same time to prevent, avoid hypercalcemia and hyperphosphatemia, at the same time to lower the PTH or prevent it from going more than 2 to 3 times the normal. Now, one compared that this is available a moment since already a couple or 3 years in the US. This is the what we call the extended release compound, which is the preparation of the pre-preparation of 25 HD, which is very slowly released in the intestine tract because it puts in some waxy formulation, and it takes a steady long time to reach the optimal reabsorption. Now the reabsorption in steady state is only reached after 3 months, and elimination half-life of ERC is about 11 days in healthy and 25 days in subject with a chronic kidney disease, and it's available in 30 and 60 microgram. And يعني this is I will leave it يعني just to look at it. We can probably talk about it later, but it has been used in Europe, and it still has not been used that frequently in the US, but in Europe they're using it. And this is a good study where 2 parallel phase studies in which a total of more than 400 patients were started with 30 microgram of ERC daily, and then with those patients insignificant efficacy could be titrated up to 60 microgram daily. And from this trial, over half a year, about 300 patients entered the so-called open label extension study, and the endpoint were the effect on 25-HD and on PTH level. And here you can see the pooled result from the study on PTH. You can see that it did lower the PTH level when you use the ERC, and when you added it after 6 months to patients who were not taking the ERC, it did manage to lower the PTH level. And the effect, of course, the effect on calcium and phosphate was not that significant. But the one thing that you have to understand, that you really have to get your 25 OHD above 50 to get that effect. So once you get the use of ERC, once you get the vitamin D 25 OHD above 50, and actually people recommending to go above even reaching 80, you will get the best results. Now, this is my last slide. So in summary, in chronic kidney disease patient, stage 3 and 5, the optimal PTH level is not known. As physician, our aim is not treating elevated PTH serum level, but their pathobiological consequences, bone and the vessels especially, and we must find a way to find out whether this pathobiology is really happening. طبعا in order to judge PTH level right, we must always consider looking at calcium, phosphorus, and perhaps even considering bone alkaline phosphatase level in parallel, at the same time. Now, in non-dialysis chronic kidney disease patient, active vitamin D analog possess an associated hypercalcemia risk and should be only used in significant active and progressing secondary hyperparathyroidism. And ERC seems less hypercalcemic and less hyperphosphatemic, while it lowers PTH effectively. Treatment effects, however, essentially depend on reaching higher 25 OHD serum level, as we said, to keep it around 50 to 80 nanogram per ml. And with that, I thank you very much for your kind attention, and I would stop my sharing my screen or my presentation and be available for questions and answers.